Assalamualaikum and good morning. Thank you to the organizing committee for inviting me to share this topic, which is pregnancy and Ramadan fasting. This will be my outline of presentations. I'm going to talk about diabetes in pregnancy and fasting, the risk stratification tool, whether the patient need to be advised to fast or not to fast, guideline on managing hyperglycemia in pregnancy during fasting in Ramadan, and that is in reference to the DA guideline 2021, and lastly, my conclusion. There is associated increased risk of both hyperglycemia and hypoglycemia in diabetes in pregnancy and in women who fasted during Ramadan. And there's small number of studies to show that women with GDM, when they were on diet alone or diet with metformin, and some of them treated with insulin, there was an overall improvement in hyperglycemia, and there's also increase in the risk of asymptomatic hypoglycemia. However, there is not enough evidence to change the high risk status of fasting during Ramadan for women with GDM. And in these studies, it was conducted on motivated volunteers and in centers with high level of skill and support. And of course, fasting for women with pre-existing type 1 and type 1 diabetes or type 2 diabetes is more challenging, and they should be advised not to fast until further research is available to support any changes in their risk categorization. Let me share with you this study which was done in Malaysia, and this is done by our UKM colleague, which was published in 2011, where they looked into glycemic control among pregnant diabetic women on insulin who fasted during Ramadan. And this was a retrospective study carried over a period of 3 years, and this included pregnant diabetic women who were on short-acting, intermediate-acting, or combination, and they were fasting during Ramadan. So they had 37 patients, and nearly 65% of them who had type 2 diabetes, and the rest were GDM, and they required short-acting, intermediate-acting therapy. They were about 32. The median age was 32 years, and they fasted with a median number of days of 25 days. They noted that in this study, there was no difference between glycemic control of type 2 diabetes mellitus and gestational diabetes prior to fasting. And in the middle of Ramadan, the serum fructosamine decreased in both groups. However, only serum H1C reduced in gestational diabetes mellitus after Ramadan. And the author concluded that these findings indicate that the pregnant diabetic women on insulin were able to fast during Ramadan, and that their glycemic control was improved during fasting period. And they may also suggest that instead of absolute ban on fasting for pregnant women, more practical approach and close consultation with healthcare providers might be more helpful. And of course, in this study is a small study which included only 37 women. Let me share with you my experience at looking hypoglycemia among insulin-treated women with diabetes in pregnancy during Ramadan. What were the objective of the study was to look at the blood glucose control during Ramadan, and we compared the finger prick self-monitoring, this SMBG, and continuous blood glucose monitoring during Ramadan. And we also wanted to see the risk of hypoglycemia and the need for insulin adjustment during Ramadan. These were the 10 subjects that we had. And if you look at the highest reading, the blood glucose went up 16.9 millimole per liter. And they actually had quite low blood glucose, where you see the lowest reading has gone even lower as 2.3 millimole per liter. And only one patient did not have any hypoglycemia during fasting and completed the whole Ramadan. But most of the patients here, if you can see, had quite high percentage of hypoglycemia. There's also one patient who subject 9 had 23.3% of hypoglycemia. But despite this, most of the patients fasted most of the days during Ramadan. This is a difference between percentage of hypos on SMBG and CGMS. If you look at this, of course, you would expect that the CGMS will give higher percentage of hypoglycemia compared to SMBG, but they are a bit different. But when we did a calculation looking at the median percentage of hypoglycemia, we did see that the CGMS has a higher detection of percentage of hypoglycemia compared to SMBG. This is a typical glucose pattern that you can see. I mean, this is not just in pregnant ladies, in other type 2 or type 2 diabetes patients who fasted, the typical blood glucose, the postprandial excursion you can see is during iftar. If you look at this, the blood glucose is high. And if you look at this pattern, where the blood glucose during the afternoon at 12, it was persistently less than 4 millimole per liter, and these patients are asymptomatic. So what we concluded from this are only 10 patients, but the results are quite significant. We noticed that the hypoglycemia occurs frequently, often without symptoms, in insulin-treated women with diabetes in pregnancy while fasting during Ramadan. And it's important to educate these women regarding their increased risk of hypoglycemia and to ensure adequate blood glucose monitoring be performed in those who plan to fast. So let's talk about the risk stratification tool, whether the patient can fast or not to fast. Of course, when we talk about fasting, whether the patient can fast or not to fast, there's few things we as medical professionals, we give recommendation, but there's also other factors such as personal choice and religious practice. And I'm sure that everybody has experienced that when you tell the patients you are high risk, you cannot fast, the patient still fast. And it's important for us as medical practitioners to make sure that they have safe fasting. So these are the elements for the risk calculation. This is based on the DA guideline. And if you can see this, there are a lot of elements that you look for the risk calculation that depends on either they are type 1 or type 2 diabetes, the duration of diabetes, presence of hypoglycemia, and even the treatment, the blood glucose monitoring, and whether they had acute complications and whether they have complications. And I want to highlight here at this 10, which is pregnancy. If they are pregnant and not within targets, they have 6.5 score. And if the blood glucose is within targets, they have 3.5. And of course, you need to also include other complication if they have. So this is what I've told you, the scoring 6.5 and 3.5. And you also have other risk element that you add to the risk score beside the pregnancy. And the scoring is very important because you need to look at the scoring, and this tells you whether the patient is which category of risk. If they have a score of 0 to 3, they have low risk. And if 3.5 to 6, they have moderate risk. And if it's more than 6, they have high risk. And of course, if the individuals have score of more than 6 in the high risk category, they should not fast. In the moderate risk, they are advised not to fast. And at the lower risk level, they should be able to fast. Let's look at the guideline on managing hyperglycemia in pregnancy during fasting in Ramadan. What is important when the pregnant lady who have diabetes who decide to fast? It's important that we detect them and know this group of patients. We need to understand, we need to identify them earlier. The reason is because we need to educate them. There should be formal education, and they should be informed the risk of blood glucose excursion to the mother and the baby. And they also need to be told that the changes to normal lifestyle that fasting can bring must be emphasized, and they need to be told that the importance of increasing the frequency of blood glucose monitoring, and the best if they can do it continuously or using flash glucose monitoring systems. And what about the physical activity? They can always maintain the normal levels of physical activity. And another important physical activity that happen during Ramadan is Tarawih prayer. They need to account this in decision on the dose adjustment, because we notice that this also is quite significant physical activity that will lead to a dose reduction for some of the patients. Expert advice from a nutritionist must be sought. Fruit juices, sugary beverages should be avoided, although it can be a challenge during Ramadan. Caffeine and salty foods should also be limited. Pre-Ramadan focus education is essential to safe fasting, and studies have shown that only about 2/3 of these patients receive such education, and there is a need to increase education of healthcare professionals and people with diabetes for optimal Ramadan fasting. And the education program should include guidance on the risk of fasting, the treatment modifications, the blood glucose monitoring, management of diabetes, when to break fast, and the nutrition and physical activity. Most of these pregnant women, when they talk to you, discuss with you about their blood glucose control, they will usually negotiate with you and say that it's Ramadan, it's only 1 month, it's okay if I have a slightly higher blood glucose. It's important for the ladies to understand, the pregnant woman to understand that regardless of their fasting status, they need to sustain the standard blood glucose targets, where the fasting should be 3.9 to 5.3 millimole, and the postprandial should be less than 6.7 millimole. And they also need to understand that during pregnancy, they should break their fast if the blood glucose is less than 3.9, and that is during fasting hours. They feel unwell, and when there is reduced fetal movement. And we will need to advise that the importance of regular blood glucose monitoring. And at the very least, they should test before the sunset meal, 1 or 2 hours after meals, and that depends on the individual's patient's routine of 2 or 3 meals during Ramadan, once during the day while fasting, particularly in the afternoon, and any time when they feel unwell. So what about the insulin therapy? There are advice on how they adjust the insulin treatment. For those patients who are on insulin pump, the basal rate adjustment, they need to decrease 20 to 40% for the final 3 to 4 hours of fast, and they need to increase about 10 to 30% for the initial few hours of iftar, where there will be postprandial hyperglycemia. And for the bolus doses, the same principles as prior to Ramadan, and reduce the dose post-sahur by 20%. And the best for those who are on insulin pump, the best type of monitoring will be continuous glucose monitoring. If the patient is on basal bolus with analog insulins, the basal insulin need a reduction of 30 to 40%, and it should be taken at iftar. For the rapid acting, of course, the lunch will be skipped, but the dose at sahur to be reduced 30 to 50%, and the dose at iftar to be adjusted based on the 2 hours post-glucose reading. For those patients who are on basal bolus with conventional insulin, for the basal insulin, the morning pre-Ramadan dose to be taken at iftar, 50% of the pre-Ramadan dose to be taken at sahur. And for the regular insulin, it is about the same as when they are on analog insulin. However, the sahur dose should be 50% of the pre-Ramadan evening dose. And if they are on premix analog or conventional, shift the morning pre-Ramadan dose to iftar and inject 50% of the pre-Ramadan evening dose at sahur. So most of the guideline will tell you to reduce the dose during sahur. Of course, our patients will eat less during sahur, the importance of reducing the dose at that time. And importantly, and if possible, you would like the 5 to 7 point glucose monitoring for these patients, although you can see that most of the patients will not do that. So, ladies and gentlemen, this will be my conclusion. There's not much evidence on pregnant women with diabetes during fasting. There is high risk of fasting among pregnant women, And this is especially in women with type 1 and type 2 diabetes. Patient education prior to Ramadan is essential to ensure mother and fetus safety regardless of fasting decision, and regular blood glucose monitoring should be conducted and at the very least once before the sunset meal, 1 to 2 hours after meals, once while fasting, and anytime feeling unwell. And the pregnant woman must break their fast if they feel unwell and if the blood glucose is less than 3.9 millimole per liter. And if they are treated with insulin, the dose of the insulin should be adjusted according to the insulin regime. Thank you.